I can't hear you, unfortunately. I'm not get this over on the computer audio. You can hear me. This thing. Okay, we're gonna go ahead and try this. If anyone can respond to me real quick, if you can hear me, we've had some problems on my end getting this going.
We can hear you great.
We are going. All right. Well, thank you. I apologize for the delay there, getting everything together, but thank you all for being with us this morning, or this afternoon, I should say now. Thank you for joining our community conversation regarding stroke. My name is Tony Mullen. I'm a morning news anchor at KRCG TV 13 in Jefferson City. First and foremost, hope everyone out there is doing well. Your families are healthy. Quick housekeeping note to our participants. All participants are in listen-only mode. There's no video, except for me, I guess, on here right now. We'll see if we need to fix that. You can click chat at the bottom of the screen to activate that chat. If you want to engage with some other participants, make sure you type in your question in the chat before hitting send. We will have some time at the end for questions. You can feel free to put those in the chat throughout the event. We'll come back to them. This is being recorded. It will be available post-event for all to share. Both the AHA and SSM St. Mary's will be sharing it. And this afternoon, over the next hour, we're going to be hearing from 3 local experts from SSM Health St. Mary's in Jefferson City, and we want to thank them for joining us today. I would like to thank SSM St. Mary's for their support of the American Heart Association here. You have enabled us to continue to serve AHA's mission to be a relentless force for a world of longer, healthier lives. The American Heart Association is deeply concerned about the public health crisis facing our country. The top priority regarding coronavirus is the health and well-being of all individuals and their families today and in the future in every community. As you probably know, May is American Stroke Month. We're excited to be here today with an incredible group of panelists to explore the latest advancements in technology to diagnose and treat stroke patients and answer any questions you may have out there. So we have 3 panelists for you today, and I'm going to introduce them, and they're going to join us. Speaking first will be Dr. Mike Chen. He is a board-certified neurologist specializing in stroke and vascular neurology. He completed residency at the University of California, San Diego, and completed the Stroke Fellowship at Northwestern University in Chicago. Since then, he has been working with Savaro as a teleneurologist and telestroke specialist, providing coverage for many hospitals across the nation. He's now the regional director for Savaro and currently lives in Seattle, Washington. And we're going to turn it over now to Dr. Chen.
Hi, everyone. Can you guys hear me okay?
I can, yes.
Okay. Thank you, Tony, for introduction. And thank you, AHA and SSM St. Mary's for this opportunity to come and speak with you guys. So as Tony mentioned, I'm one of the stroke neurologists working at Savaro, and I'm also one of the regional stroke directors as we're expanding. And we're a telehealth company that specializes in neurology, mainly telestroke, but we're expanding into other fields of teleneurology with rounds, and we'll get into that a little bit later. So I think before I start, I'll give a brief sort of introduction to how the stroke world has progressed, in the past 25 years, and how much more we can do these days compared to, even 10 years ago in the acute treatment of stroke care. So TPA, as you guys may or may have not heard of, it's a clot-busting medication that was approved by the FDA almost 25 years ago or more. And since then, it has been used to treat ischemic stroke or acute ischemic stroke patients that come into the emergency room mostly. And even in the past 10 years, with the advent of endovascular therapy, meaning that a clot, there's a clot in one of the arteries, neurosurgeons or interventionalists, they can actually go after this clot through a growing approach through the arteries itself and try to take the clot out. So both of these contribute significantly to decreasing stroke death, stroke mortality, and decreasing disability from stroke. And as we all know, stroke is one of the leading causes of disability in USA, and one of the top causes of death in the USA as well. And since both of these has been implemented very well in the past few years, or the past decade or so, all of that has been decreasing. And for most hospitals across the USA, actually, the majority of the centers, academic centers, have both of these available. And for some of the community hospitals and rural hospitals, most of them only have this medication available for the acute stroke treatment. So what telemedicine and what sort of Savaro brings to the field is that immediate access to a specialist in neurology, vascular trained or neurology stroke trained, that can actually guide treatment of medication, as well as guide further interventions as to transfer of these patients to higher levels of care to other hospitals that can perform the thrombectomy. And since the telestroke has been around, or telemedicine has been around for nearly a decade or more, however, given the past year of the pandemic, I think that has been drastically accelerated and drastically put into implementation, approved by federally as well, to be using some of these technologies to enhance care at these community and rural hospitals that usually do not have a specialty service. And Savaro, we have been partnering with SSM Health for the past almost a year and a few months now, and we have dramatically increased patient satisfaction, decreased stroke death, and decreased stroke disability. And both of these, is now possible without the technology we have today and the real implementation. So what actually happens when a patient comes into the emergency room with an acute stroke is that we, or the teleneurologist, gets called right away by the emergency room physicians. And then there's a real-time video conference where we log in just like this through a Zoom conference or another device, where we see the patient in a real room with a nurse, or usually a nurse or a physician at the bedside that can help us guide the examination. And once the interview and exam and imaging is reviewed, we can determine if the patient is a good candidate for this clot busting medication, and or if the patient is a good candidate for clot retrieval, in which case most of the time the patient will be transferred to another stroke center, most likely at an academic center or a urban center. So not only do we do the acute emergency setting stroke treatment, we also extend that to following up with these patients if they're admitted in the hospital on teleneurology rounds, and also leading to improve the whole process of the patient workup and discharge. And ultimately this benefits significantly in terms of the times that we have and in terms of patient outcomes and their improving their disability. So our focus from the Savaro point of view is using the technology, using this advanced the knowledge that we have from our backgrounds and training to really give care to the areas that need it most. And from the research that we have, most of the community and rural hospitals have dramatic benefits from using telemedicine and using especially a telestroke service with us. So that being said, I'll turn it back to Tony, and we can answer the questions afterwards. Thank you.
All right, Dr. Chen, thank you very much. We're going to introduce now Dr. David Brummett. He joined the SSM Health St. Mary's Hospital medical staff in 2015. He is a radiologist with JCMG. Dr. Brummett received his medical degree from the University of Kansas School of Medicine completed an internship at Good Samaritan Hospital in Phoenix, and completed his residency at the University of Nebraska. He also completed a fellowship in neuroradiology at the University of Indiana. Dr. Brummett is board certified by the American Board of Radiology in diagnostic radiology and neuroradiology. He has a special interest in spine and cardiac CT, prostate MRI, image-directed procedures, including pain treatment-related procedures such as vertebroplasty and steroid injection. Dr. Brummett is married, has 4 children, and lives in Columbia. Dr. Brummett?
Hello, thanks for having me, and thanks for putting on this event. Next slide, please. Great. So I'm going to talk about imaging of stroke at St. Mary's Hospital. And virtually every patient who is treated for stroke or even considered for stroke treatment has imaging. And that's because it is so important to directing whether or not a patient can be treated and how they're going to be treated. Next slide, please. So at St. Mary's, we have the full complement of stroke imaging studies. There's 4 of them listed right here. The first 3, the CT exam, the CT perfusion study, and the CT angiogram study are all part of our stroke protocol. So what that means is when somebody comes to our facility and we image them, we do all 3 of these on most of our patients. And there's very specific reasons for that I thought I'd go over with you. The first one is the CT. So if you just look at that picture, the really dark part, that's actually a stroke as seen on CT. And CT is a great study. It's been around since 1972. It's really fast, and it's really good at picking up hemorrhage. And that's important because the TPA, or clot busting medication that Dr. Chen talked about, is very effective for opening up vessels that are occluded due to stroke, but it's also very detrimental to somebody who has blood in their brain because it'll make the hemorrhage worse and make the patient's condition worse. So we do the CT largely to make sure there is no hemorrhage. The part where CT fails or is inadequate is that it's going to miss at least half of the strokes that present within the first few hours of a stroke. So that's why we use the second study, which is called a CT perfusion exam. It's been around since the 2000s. We've had it here at this hospital since I joined the hospital in 2015, but great study. You give the patient contrast, you image the brain while the contrast goes through the brain, and then you produce these really nice maps like you're looking at right here. So in this case, everything that's blue is the stroke. And so now we've improved our ability to pick up a stroke to about 85%, which is significant. And what's even more important, in my opinion, is actually we can determine whether or not the brain tissue, which is involved with the stroke, can be saved if we can restore blood flow. That's called penumbra. So with this image here, we can see if the stroke is present, and we can see if we have an ability to save the brain. The final image here is a CT angiogram. And so this is our chance to look inside the vessels to see if there's a clot inside the vessel, which happens about 20% of the time. So if you look at this image, you'll see one half is red, and you see that little white line that leads to the red. That little white line stops on that side because there's a clot right there. And the red part tells us whether or not the patient has good collateral circulation. So if a person has good collateral circulation, the stroke will grow much more slowly. If they do not, the stroke will grow faster. So we get information there in terms of whether or not there's a clot inside the vessel and how quickly that stroke is growing. And again, we do all of that within 30 minutes. Oh, and then finally, the MRI is the final study I'm going to show you here. That is the best way to image a stroke. It picks up nearly 100% of strokes. And in this case, the white part in this brain is where the stroke is. Great study. The only downside with it, or couple are, is that if somebody has a pacemaker, or they're combative, or they're unstable, they cannot have an MRI. And that's one of the reasons we use CT and CT perfusion as our go-to exam. A lot of times we'll come back later and get the MRI. But that's what we offer at this hospital, and I think we have a pretty good system. Next slide, please. Finally, just why do we do all this imaging? And I've kind of covered most of these, but the first thing we want to do is we look for a brain bleed, because that's a contraindication to therapy, like I talked about earlier. We want to exclude mimics of stroke, such as a brain tumor. And that's because you don't want to treat something with a pretty powerful drug if it's unnecessary. And if you have a stroke mimic such as a tumor, that's actually a contraindication to the medication. We'd like to identify a stroke if it's present. Having said that, as weird as this sounds, if a person presents classically like a stroke and they don't see the stroke, there's still a 15% chance that we're not going to be able to see it. And so some cases, it's up to the neurologist. They may still want to treat the patient. We want to look for that brain tissue that can be saved, and that's the penumbra. Very critical to the entire treatment process, probably the most critical part. We want to identify vessel occlusion. So like Dr. Chen mentioned, at our center, we're called a primary stroke center. So we can give the clot busting drug in the vein. So if they show up to our facility and we see a clot in the brain, we can treat them with IV stuff if they show up within 4.5 hours, and then ship them up to a comprehensive center to take the clot out. Or if they present without a vessel occlusion within the right time window, we can treat them here and then observe them here. And of course, the final part, we want to do all this very fast. For every 1 minute of stroke, nearly 2 million neurons die. So the quicker you do all this process, the better it is for your patient. And that's all I have to say for now. Thank you.
Okay, Dr. Brummett, thank you very much for that information. We're going to introduce our third panelist now. This is Dr. Joanna Younker. She earned her medical degree from DeBusk College of Osteopathic Medicine and completed her residency at the Palm Beach Consortium for Graduate Medical Education at St. Lucie Medical Center in Florida. She is board certified in family medicine and osteopathic manipulative treatment. She holds a professional membership with the American Osteopathic Association and is a diplomat of the American Osteopathic Board of Family Physicians. In addition to full spectrum primary care, Dr. Younker's professional interests include women's health starting in adolescent years, continuing through childbearing years, and supporting in the transition through the emotional and physical changes of menopause. She enjoys traveling, being outdoors, knitting, hiking Missouri trails, and spending time with family. And I'll turn it over now to Dr. Younker.
Hi, everybody. It's so wonderful to be here to give this presentation today. And thank you for Dr. Chen and Dr. Brummett for their presentation. So I'm going to just take it back to more of a, what do we do in the primary care office? Because a lot of times you're going to see me and be treated by your primary care doctor even before you are in the hospital setting. So I'm going to be talking today about risk factors and prevention of stroke, kind of the practical information you can take home today. So the bread and butter of primary care is really going to be the things that are the highest risk factor for causing stroke. So that would include hypertension, diabetes, and heart disease are going to be some of the major risk factors. The heart disease part of it, I guess, would also encompass vascular disease. So, you know, things that can cause blood clots, make your blood more likely to clot. You know, if you have a heart valve disease, that can increase your risk of having clots, coronary artery disease, and atrial fibrillation, which is very common and increases your risk of having strokes as well. High cholesterol is another thing that can increase your risk of having a stroke. One that is kind of the buzzword lately is smoking. So smoking absolutely does increase your risk of having a stroke. And then I always like to say, you know, age is also a risk factor. Of course, we don't want to blame everything on age, but age is one of those things that as your age increases, it's something that we are definitely looking at more closely. Gender is something else we look at. You know, young men are more likely to have strokes than younger women, but because women have a longer lifespan, typically women will have a higher lifetime risk of having stroke. And then there are some increased risk factors for your race as well. So if you're a part of Hispanic population, Native Americans, or African Americans, there's an increased risk as well. So these would be important things for you to talk to your primary care doctor about, your healthcare provider, just to kind of identify your risk and ways to prevent a stroke. As we talked about, stroke does cause major disability and can cause death as well. So when we look at prevention for primary care, that's really where our focus is. And we do look at the ABCs of stroke prevention. So the A would stand for aspirin. Not everybody is indicated to be on aspirin. There are some very specific indicators. And so you can talk to your provider about that. The B of ABCs would be blood pressure control. So, you know, if you have uncontrolled hypertension, long-standing, that's going to greatly increase your risk. But even if you have hypertension, if it's able to be well controlled within guidelines, then that's going to decrease your risk. And then the C of ABC would be your cholesterol. So keeping your cholesterol low, especially if you do already have known heart disease or vascular disease. And smoking cessation, of course, this is a buzzword in clinic throughout the day, just really supporting the patient to work on smoking cessation to decrease the risk of cardiovascular stroke. And then lifestyle-wise, you know, the best way really to prevent stroke is to have a healthy diet. The more you do a plant-based diet, the better it'll be, especially obtaining your protein from plant sources rather than from animal sources. And then maintaining healthy weight, regular exercise throughout the week, and then limiting your alcohol. So if you're a man and you're drinking more than 2 alcoholic drinks per day, or for women drinking more than 1 per day, you know, that can increase your risk. And then the new buzzword in my clinic lately is sleep apnea. So sleep apnea is being identified as a risk factor for having strokes. And so diagnosing and treating sleep apnea is one way that we've been targeting prevention for strokes lately. And so, you know, sleep apnea can more than double the risk of a stroke for middle-aged and older men. So that's something that we're looking at as well. And I guess that's the main things I have to talk about today, and look forward to your questions later. Thanks.
All right. Thank you, Dr. Younker. And thank all of you for this wonderful information. I'm sure that all the attendees learned something today that they didn't know. Today and every day, it's important that we stand together to be a relentless force for a world of longer, healthier lives. Again, if you have some questions, please let us know. We do have some questions that came in before the call. We'd love to have those answered. Again, you can use the chat pod if you have any more questions, and we will get to those here in a little while. Dr. Younker, we'll start with you with this question. Can stroke patients fully recover?
Yeah, thank you for that question. So the answer is yes, especially if they are treated quickly and in the hospital setting. If either there's a bleed and that can be treated with neurosurgery, be decompressed. If there's a clot and that can, you know, if they either that clot is retrieved, or if they're able to do the TPA clot busting medicine, you know, you can actually preserve those neurons from being permanently damaged. And so the answer is yes, you know, you can completely recover from a stroke, but there is also the possibility that there may be long-lasting neurodeficits, which is why it's important to prevent the stroke in the first place if possible.
Dr. Chen, we'll direct the next question your way. Can you describe what a TIA or a mini stroke is?
Yes, thank you, Tony. That is actually a very interesting question. I think I'll go in a little bit more about what a TIA is versus what a stroke is. So TIA stands for transient ischemic attack, and I think there's been a lot of confusion even in the medical field that, you know, any sort of neurological symptom may be a TIA. That is true to some extent. However, I think, you know, from a neurologist point of view, a TIA is basically like you had a stroke. That is, you know, the fast symptoms that we talk about usually, or be fast in this case, balance issues, gait instability, vision issues where you lose actually a vision, not necessarily floaters or flashing lights. And the F stands for facial droop. The A stands for arm and leg weakness. And S stands for speech, where you have trouble getting the words out or slurring of the speech. And then the T is not a symptom, but it's rather an indication or a reminder that we should be fast with the timing, meaning coming into the ED, getting help immediately. So once we have those symptoms and you're having one of those symptoms or a combination, usually it's a combination of those symptoms that dictate that if this is a clinical stroke or not. And once you have something like that and it goes away completely and you're back to normal, that's technically what a TIA is. It's you had a stroke or you had some symptoms and now it's completely gone. If you come into the emergency room and you're telling us that you had these symptoms for about, let's say, an hour, now it's completely gone, we suspect that it may be a TIA, and we'll do the workup as if you had a stroke, but not necessarily any TPA or any acute intervention like I talked about before. But if you're having the symptoms still ongoing and it's never really gone away, and in that case, that's clinically a stroke rather than a TIA. So I think we can talk a lot more about this, but that's the basic gist of it. Okay, thank you.
All right, Dr. Younker, we'll return to you for this question. Are strokes hereditary?
All right, are strokes hereditary? So I think that yes, there are some direct medical conditions. They're very rare that would be a truly hereditary cause of stroke, but for the most part, those conditions that put you at high risk of stroke, those are the conditions that are typically hereditary. So if diabetes runs in your family, if hypertension runs in your family, then yes, that is by way of going to make you at an increased risk of stroke because of your genetics. There are some autoimmune conditions like lupus, for example, that can be hereditary and can increase your risk of stroke, or even other inflammatory diseases. And then we think about those conditions that can either cause your blood to bleed too much, or the opposite, conditions that cause your blood to clot too easily, and those can be genetic. So by way, I would say yes, they can be hereditary.
Dr. Brummett will direct the next question your way. As far as how long a stroke will show up on CT, is it there for life?
It depends on the outcome of the patient. So if there's complete resolution of the stroke, in some cases, you'll never be able to tell on future scans that they've had a stroke. On the other hand, if there's a partial impairment, or worse, they just don't have a good outcome, you will see it for life. And that's because the brain tissue will scar down, and that's called gliosis, not that it matters, and also because the brain tissue is damaged, it'll eventually shrink. So on later scans, you'll see the scar tissue and you'll see brain shrinkage due to the stroke.
Okay, Dr. Chen, we'll direct the next question your way. Signs and symptoms of a stroke, do they differ depending on a patient's age?
Usually with a patient in adulthood or even early adulthood, the symptoms of stroke usually do not differ too much. It's the symptoms that I talked about. The causation of the stroke may differ quite drastically. If you're a younger patient, let's say, anywhere between 18 to 40 versus someone who is older, above age 65. And that's something to be teased out. And in very young patients, and it's rarely they have strokes, like in teenagers or kids, the stroke presentation can differ quite a bit, and it can be confounded to the point where it doesn't look like a typical stroke, and that's where sometimes the delay comes from in getting those patients to a hospital setting. But the short answer is no, they usually do not differ.
Dr. Younker will send this question your way now. For people who may have been smoking at one point, if they quit smoking, say 30, 40 years ago, are they still at risk for stroke?
So one thing that I like to talk to my patients about with smoking cessation is all the positive things that come their way. So a lot of times we tell them all the terrible things that will happen to them if they continue to smoke. But I think a much better approach is to keep it optimistic, keep it positive, to know that it is never too late to quit smoking, even later on in life. Because we know that with strokes, once you hit about the 5-year mark, your risk starts to go significantly down and continues to decrease from about years 5 to 15 after you quit smoking. And so by the time you get to about 15 years after smoking, your risk is about the same of a non-smoker. And we look at that with lung cancer risks, will be your risk of lung cancer death will be cut in half even 10 years after smoking. Your cardiac risks will go down, significantly. Even at a year, your risk will go down by half. So it's never too late to quit smoking to decrease your risk.
Dr. Chen, we'll go back to you. I know as we've gotten into the pandemic, we had certainly an increased video visits and seeing your doctor over video. If you're looking at a patient over video, can you see them clear enough to see if they're having a stroke?
Yeah, I think that there's a lot of concern about, how much we're able to see the patient over the camera. I think from at least the acute stroke treatment perspective, what we see, the video quality usually is very good. So, if we use something like Zoom or one of the other video programs that we do use, the quality is good enough that you can zoom in on the patient's face, and it's still very high quality definition. And you can see their teeth, you can see, if they have a facial droop. And what we need to know at the moment when they come in and on video is whether they have profound weakness on one side, whether there's an obvious speech difficulty, and all of these can be very easily picked up just by looking how the patient is interacting with the staff at bedside, how the patient is talking or motioning. And just a little bit on stroke diagnosis. A stroke is technically not diagnosed based on imaging. It's diagnosed initially when we assess the patient at bedside or on camera in this case. And a neurologist will tell you that we do give TPA based on a clinical presentation, and we don't give TPA or the treatment medication based on imaging alone. Obviously, the imaging will help us confirm the stroke or help us make a decision, and it's much easier. But we don't need extraneous imaging to make a decision about stroke treatment in the initial phases.
Dr. Brummett, why do patients need an MRI after getting a CT to look for stroke?
Sure. The main reason is it's just more accurate. So when we do like the CT perfusion study, we're basically imaging 8 centimeters of the brain, but the brain is actually 16 centimeters long. So there's still a chance there could be a stroke beyond our field of view. And also there's these really small lacunar infarcts due to these perforating vessels called lacunar infarcts. And MRI is excellent for picking those up. The other modalities are not as good. So basically it just cleans it up and gives you more accuracy in the patient you're treating.
All right, thank you for the answers to those questions. We do have several that have come through on chat here. We're going to go through some of those here over the next several minutes. I guess this will be for any of you. Have you noticed any impact that the COVID pandemic has had on stroke patients?
I guess I can answer that first. So from the acute stroke point of view, there has been case reports that COVID itself, like any viral infection, can cause a state of clotting inside the bloodstream. We did see that in terms of stroke patients coming to the ED or coming to an emergency setting or the hospital, over the past year during the pandemic, that has decreased dramatically because of patients wanting probably to stay home or delaying their presentation to the hospital. In terms of COVID causing strokes, I don't think we've seen too many increased cases. The case reports that are coming from New York and all the initial reports are that in younger patients with COVID and with sicker patients in a hospital, there's an increased risk of hypercoagulability or clotting because of the fact that there's a virus going on in the body, and not necessarily because of it's a direct cause of having strokes.
Dr. Brummett, a question for you. Can you share your thoughts on the benefits of CPP and how this is beneficial for stroke care?
Sure. CTP is a great study, and like I said earlier, it increases your accuracy, which is always helpful. It tells you if the tissue can be saved, which is helpful. And what's really kind of exciting, it's already starting to take effect, is the information is so good that you can actually potentially expand your treatment window. So as of like 4 years ago, if somebody presented with a stroke and they had a clot, you could only give the TPA for 6 to 12 hours, depending on what study you did. But now, because of the DAWN trial and using CT perfusion, among other things, they've expanded that treatment window to 24 hours. So because of perfusion imaging, you can look at the brain and determine whether or not you can treat the patient longer, which is helpful. The other issue, and that'll be upcoming, and it's interesting because the American Heart Association, last I checked, is still wanting more information about this, but 30% of the population goes to bed normal and wakes up, among the stroke patients, has what's called a wake-up stroke, where they go to bed normal and they wake up impaired. You can't tell when that stroke occurred because they were basically asleep. And so with perfusion imaging in the future, and now in some places, because of perfusion imaging, you can actually treat those people because you can see if there's enough brain tissue to save.
Another question, not directed to anybody necessarily. Maybe Dr. Younker would want to get in on this. Should high-risk patients or a family history of stroke take aspirin to help prevent stroke?
So when we look at talking who is going to be recommended to take aspirin, the prime years are really going to be in your fifth and sixth decades of life. So in your 50s and 60s, you know, this is not going to be someone who's necessarily already had a stroke. That treatment will be different. But if you haven't had a stroke before and you don't have any you're not high risk to have a bleed, and your lifetime or the next 10-year risk of having a cardiovascular event is greater than 10%, they would be the ones that we'd recommend to start on aspirin. And so there's different calculators that we use from the American Heart Association that allows us to calculate your risk if you're in those age range. So if it's greater than 10% within 10 years, then you would be someone that we would recommend to take aspirin.
All right, another question here directed to Dr. Chen. Can you tell us about how AI is being used in telestroke?
Sure, yeah. So AI in this case, I think Dr. Brummett can also weigh in on this, is probably mostly used for initial imaging studies and initial evaluation or triaging of which patients would be eligible for acute intervention, whether it be the medication or whether it be a clot retrieval where they go in and take the clot out. And it would, I think it would not totally replace, you know, physicians or bedside evaluations, but it would greatly accelerate how we get the information across to appropriate centers or appropriate transfer areas where we need the patient to go. And that we're using certain apps right now to sort of enhance our imaging detection, enhance our imaging data collection. And those use some sort of artificial intelligence where they learn locations of blockage, where they learn patterns of blood flow within the areas of stroke, and they can give us an accurate or, you know, more accurate information on the mathematical side or, you know, decision-making side.
Can I add to that real quick? So his description was great. And in radiology, we call that computer-aided detection. And so what it can do, it can enhance what we do. We have a lot of information to process very fast. And so there's some computer power now that enables us to basically feel more confident about our very fast diagnosis, and kind of not so much an AI thing, but related to the whole computer contribution to imaging. We now have the ability to look at images and have other stroke centers look at them almost simultaneously. That's how quickly we can pass the information, which also improves patient care because it makes things faster.
Okay, next question here. Many patients post-COVID-19 complaining of being foggy in comprehension. Have you seen patients who have misinterpreted these symptoms when they were actually having a stroke? And is there a way you can tell the difference?
I guess I can answer that. So Post-COVID syndromes or complaints are quite common. There's newly published papers coming out from Northwestern, the group I was there with. They saw that most of the complaints were non-specific, unfortunately, and being quote unquote foggy is one of the very non-specific symptoms. So if you came into the emergency room saying that you're just feeling off, and otherwise you have no weakness, no speech problems, no facial droop, none of the typical symptoms that we do see, it's very hard to interpret it as a stroke just by itself, being isolated, feeling off. And I don't think we can tell at the moment clinically if this is a stroke or not. And therefore, it's very hard to give medication, the IV medication for these patients. And it's unlikely that they have a large vessel blockage as well. But, having said that, I think we always do the full workup. And in this case, the MRI will be definitive if the patient's having strokes or if the patient, this is a non-specific symptom from COVID. So you should still, patients should still come in and get evaluated, obviously, especially if this is an acute onset, a very fast onset, and this is not something that's been brewing in the background for weeks or months.
Okay, Dr. Chen, we'll keep you here. We got the next question actually directed at you. Can you speak about TNK versus TPA and if you're seeing hospitals increase use of this?
Oh, yes. So TPA is the original medication that I talked about. It was approved by the FDA about 20 years ago in stroke care. TNK is a new sort of recombinant medication that's very similar to TPA, but it has shown to have better outcomes in terms of breaking up the arteries, clearing out the clots just by itself. And it's easier to administer compared to TPA. Usually the staff is just a 5-second push into the IV system rather than a 1-hour infusion at the bedside. And the outcomes that the trials that we're seeing is that the risk of bleeding is actually maybe less than TPA. And I think that's the biggest, risk factor or reason why we have to discuss with the patients about using these medications is because the risk of bleeding, or else if there's no risk, we would just give it to everyone in that case. So definitely we at Savaro and a lot of my colleagues who are stroke trained strongly favor TNK if that's a possibility over TPA. However, it is not FDA approved right now for the care of acute stroke treatment, but it is FDA approved for acute cardiac treatments. And FDA, or I think the whole country is coming around and recognizing that TNK is probably a better medication than TPA with equal, if not better, efficacy.
There we go. I'll bring Dr. Younker back in. We haven't had a question for a little for her. Here's a question. If you've waited to receive medical attention for a stroke, when is it too late? Are you then not considered viable?
Well, I think the answer is it's never too late. Of course, if you believe that you're having a stroke, you should really seek emergent care, 911. If you're having active stroke, don't come to my office. I can't do the imaging or evaluation as quickly as they can in the ER. So even if you have waited and it's lingered and it's still present, you should really get to the hospital to seek care. One thing I didn't talk about, and one thing that was always a good answer in residency when they asked, what are the risks of a stroke? Well, if you come out of, answering after 100 risk factors, you can always say, well, one risk is having a previous stroke or having a previous TIA puts you at risk. So, you could have a mini stroke, and we know that instantly is going to put you at risk of having a future stroke event. So it still is going to be about treatment of your current symptoms, but then also prevention for a possible next.
Could I just add to that a little bit? So for the acute medication to be considered, the window is 4.5 hours. So anytime you think you're having an acute stroke or new symptoms, you should come to the emergency room right away or call 911. And and that's from the time when the symptom starts or the last time the patient was normal. So it sometimes is very difficult to tease out, and that needs to be really clarified if the patient is eligible for this medication. If the patient has a large vessel clot, that window is actually extended beyond 4.5 hours to 24 hours, or sometimes even more, depending on the situation. So in either case, it's highly recommend, like the Dr. Younker said, to come in right away and not delay any further.
Okay, it looks like we have gone through all the questions. We had one through the Q&A and had several in chat, and I believe we have answered all of them. So thanks to all of you for answering all these questions, and we'll start to wrap up here. If there are any final thoughts, we'll go through our panelists again. Any final thoughts you want to leave us with? We'll start with Dr. Chen.
Yeah, so I think stroke care, unfortunately, I think a lot of it is still prevention, and I totally agree with Dr. Younker. It's if we can prevent any stroke from happening in the first place, we wouldn't need, any of us, to be honest. But unfortunately, that's just never the case. And if you do detect symptoms, it's very important to come in right away. And the stroke care has gotten good enough in the past decade that most of the time you'll make a better recovery than if you were treated maybe even 5 to 10 years ago. So a lot of the hesitation, I think, or a lot of the delay, we should try to avoid. And in places where neurologists are not available at certain hospitals, there's the technology is there, and we can step in with stroke trained specialists across the country to provide this very vital care to the community. And I just want to thank AHA again and St. Mary's Health for hosting this event. And thank you for having us.
All right, thank you very much, Dr. Chen. Dr. Brummett?
Sure. Once again, thanks a lot for having this event. Stroke is a really big deal, and 20 years ago, I don't think people realized how big of a deal it is, but like mentioned earlier by Dr. Chen, it is the #1 cause of disability, and that's a big deal. And so having these sort of opportunities to educate people is very important. And like mentioned earlier by Dr. Younker, if somebody you think has a stroke, don't wait to see if it gets better. Come in immediately and seek treatment, because the longer you wait, the worse outcome it'll be. And also, it's an exciting time for stroke, because I feel like with telehealth and some of the new imaging modalities and just general medical knowledge, stroke care is getting better and better. And it's the future for stroke treatment is very exciting. Thank you.
All right, thank you very much. Dr. Younker, anything you'd like to leave us with today?
So I want to say thank you for having me today. And if I can say anything from the primary care side, one thing I've seen in the past year with this pandemic is really high levels of depression, high levels of anxiety, and high levels of stress. And all of those are going to potentially increase your risk of having cardiovascular disease, not managing your chronic medical conditions, not seeing your primary care doctor to have your diabetes evaluated. People are staying in more, so they're not as active, not exercising as much as they can. So I think my final statement would be just take care of yourself, take care of your emotional and spiritual health to really make sure that you can have the lowest risk of these really serious medical conditions like stroke. And thanks for having me.
All right, thank you. Thanks again to Dr. Chen and Dr. Brummett and Dr. Younker for being here and answering all of our questions today. Thank all of you for joining us on this important conversation about stroke in the community. And know that no matter who you are, where you are, the American Heart and Stroke Association is here to help you through these times. You can go to their website, stroke.org and heart.org. It has health resources. You can share it with your family. And thank you again to SSM Health St. Mary's for your continued support. Again, thanks for being with us today, and have a wonderful Wednesday.